Okay, everyone, I think we'll get started. We're at sort of a quorum of about 15 at this time. So I'm just going to go through our basic introductory slides to start with. So a reminder not to disclose any PHI during this session. And here's our usual reminders. If for contact information, you can contact Rick or Andy or me. And some background info on cardio. This is the cardio team. But today, I'll be facilitating as usual. Karen will be presenting on health literacy, which I think is going to be a really interesting and insightful discussion. We have one case by Angela. So Angela Pleasant will be presenting a very interesting case study, and Mary Lee and Karen will be our discussants. But as always, please do chime in and add to the discussion. No changes in disclosures that I could see. And Karen, take it away when you're ready.
All right, so I'm going to be talking about health literacy and cardiovascular risk with a little attention to diabetes, since that's my specialty area. And I'm trying to advance Rick, but it's not going any. Okay, here we go. Now I see the little arrows at the bottom. Okay. All right, our learning objectives are to describe disparities in health literacy which impact cardiovascular risks, including diabetes, and then talk about culturally sensitive approaches to diabetes education and list strategies to convey numerical information to patients with low literacy. So we may have heard this before, but health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Skills, of course, that are needed would include being able to read, write, and do basic calculation of numbers, and to be able to communicate with healthcare professionals. And increasingly more now, especially I notice in the diabetes area, is understanding health technology. And that may include not only meters, but CGMs and connected apps, etc. It's estimated that 90 million Americans have low literacy skills. And I'm going to discuss a big study that was done in 2003, the National Assessment of Adult Literacy. And I don't think another big one like this has been done, although some studies have been published kind of based on this information. But this was the first time they actually used assessment tools to have, to measure literacy and health literacy in adults. So they assessed 19,000 adults, 16 years of age and older, from households and from prisons. And they used the categories of literacy measurement, like prose literacy, which is reading documents with paragraphs and sentences, document literacy, which may be using information from smaller documents, brochures, pamphlets, and then quantitative literacy, being able to perform computations. And the health literacy, assessment part of it was really kind of assessing people, giving them tasks that were related to health issues. And they used three categories: clinical, prevention, and tasks related to navigating the healthcare system. Honestly, I'm not too sure how well I would do on those tests myself, because I find it very complicated. So they had a scoring, measurement, and this is hard to see, but there was 4 categories. Proficient would mean that you are pretty good. You have good skills at doing more sophisticated tasks related to healthcare, like calculating an employee's share of health insurance costs for a year using a table, or finding information that's required to define a medical term, in a complex document. Whereas as you go down, basic would be being able to just give, basic information, like interpret basic text in a more concrete way. Like give 2 reasons a person with no symptoms of a specific disease should be tested for the disease based on information in a pamphlet. And then below basic would have been, very simple concrete tasks, such as identify how often a person should have a specified medical test, or identify what's permissible to drink before a medical test. So simple sentences, very concrete, whereas as you go up into intermediate and proficient, you're reading more and interpreting more complex information. Yeah, and what they found in that study was that 53% of Americans had intermediate health literacy. That's the level under proficient. And then 12% had proficient, which is the highest level. 22% were scored in the basic category, and 14% were scored in the below basic. They looked at the population and found that individuals were more likely to have low health literacy if they were lower socioeconomic status, if they had a lower education level. So for example, if they didn't finish high school, there was only just a few percent that were in the intermediate level, and most were in the basic or below basic level. The higher their educational level, the better they did. Non-native speakers of English, those with low English proficiency, those where English was not their first language, were more likely to have low health literacy. Individuals 65 years of age and older were more likely Medicare and Medicaid recipients compared to employer insured, were more likely to have lower health literacy. Those with low health literacy were more likely to get their health information from radio and TV ads instead of printed materials. So there are some, assessment tools that people can use, and there's a number of them out there. This was a really quick and easy, fast one called a rapid test for health literacy, and gives a score. So some of the questions, they ask questions and score based on 3rd grade and below would be a score of 0, 4th to 6th grade would be a score of 1 to 3, and 4 to 6, 7 to 8. High school would be 7 and above. So they ask questions about certain topics, and and tell you how to score that. There are informal ways to assess patients' literacy levels also, and this is from the CHCS fact sheet. And asking questions like, I forgot my reading glass, if they say things like, I forgot my reading glasses, that's suspect. If they frequently miss appointments, that's suspect. If they fail to complete registration forms, miss appointments, if they're not able to name their medications or what they're for, if they're not able to give a coherent medical history, if they don't follow through with getting labs done or going to referrals appointments, that would be, suspect maybe for a lower health literacy. Questions that you might ask as a healthcare professional to assess health literacy would be, a lot of people have trouble reading and remembering health information because it's difficult. Is this a problem for you? Or What do you like to read, or how do you like to learn best? Everyone has a unique source. What do you use? TV, radio, internet, friends or family? The impact of low health literacy is that it's very costly, 4 times higher the healthcare cost for those with low health literacy. There are medication errors, low rates of treatment adherence because of poor communication between patient and provider, reduced use of preventive services, more ER visits, poor chronic disease management, longer hospital stays, more frequent hospital visits, and they're less responsive to public health emergencies. Related to diabetes education, I'm referring to a study here that was done in Vanderbilt University, and it's called the Diabetes Literacy and Numeracy Education Toolkit. So based on the results of low health literacy, affecting diabetes education, they developed a toolkit. But what they found is they looked at 398 patients, 83% of which had had diabetes education previously, and 25% of them couldn't determine what glucose meter readings were within the normal range of 80 to 120. 56% couldn't calculate carb content on a container of snack chips, and 59% couldn't accurately calculate an insulin dose based on blood glucose level and carb content. So they developed a toolkit for diabetes education program consisting of about 24 modules. And some of the tips they gave for developing materials are included here. Wording should be very simple. The messages should be short. Keep them on a 4th to 6th grade reading level. The information should be limited to key points, minimize, disease statistics, anatomy, physiology, and clinical jargon, and focus on key actions and desired behaviors. Use pictures to convey the message, not just to decorate the page. And then they used color coding just to help people, like, this is information related, this is an action step, or something like that. They color coded their materials to help people figure out what to do with that information. And then they encouraged shared goal setting between patient and healthcare professional. So they show some examples of those handouts, and what you'll see here again, see if I can blow it up a little bit. I can't. There's lots of white space. They also mentioned that headings and bullet points, boldface is very helpful. Not too many words on a line, and the font should be at least 12. So the picture should convey the message, and not too much wording. So that's an example of that. This is an example of the food label. So you have the nutrition facts, but it's guiding the user, saying, what is the serving size? How many carbohydrate grams are in the serving? So a nice little educational tool that's not too complicated. I don't know if you've seen handouts that describe how to understand the food label, but they can look like, I don't know, maps or something with all the arrows, and I think it can be very confusing for people. So this is just really zoning in on, for people with diabetes, what they need to know. It's an awful lot of information on a nutrition facts panel, and maybe not all of it's necessary to do the job. Here's directions for how to take your insulin. So they've got pictures to convey messages. So this is breakfast, this is lunch, this is dinner, this is bedtime. And then, the instructions are clearly written here. If your blood sugar is this, take this many units. So it's just really spelled out. And I know a lot of practitioners will do like a correction scale, print it out and give it to their patients, but this was their use of it. The teach back model is really recommended too. And so the teach back model, a method I know we've talked about before, and the website to see a little bit more information about it is there. But the clinician would give the message or demonstrate a skill and then ask for a teach back. So ask the patient to repeat the message using their own words or return demonstrate a skill. Any errors or misunderstandings are corrected by the clinician and the patient asked to repeat back, but always with keeping a respectful attitude in mind and not embarrassing anyone. So, you might take responsibility for the way you state your question to them, like, can you do this? Can you show me how to do this? Or instead say, I want to make sure I'm explaining this clearly to you. Could you repeat back to me in your own words what I've explained, so I know I've done my job well, and a lot of times just personally, when I'm sitting with a person for a while and I'm zoning in on what I think they need to know at that visit, before they get up and leave, I'll say, if you're about to walk out the door and you're thinking to yourself, what's the most important message that I got here, what would it be? So sometimes, I'm really happy because they got it. And sometimes they give me a blank stare like a deer in a headlight. And I know I have not done my job well. So we'll summarize the messaging. This is another tool I'll use. I had a student make this up many years ago, but just a teach back for carb counting. So we talk about high carb foods and low carb foods, and I show them the handout, let them circle it, which ones are on the high carb list, or I might say which ones are not on the high carb list, and it just gives them a little hands-on practice. And it's surprising, no matter what educational level the people are coming in with, you may be surprised, they just don't think about food in that way. So you're really teaching them to think about food in a specific way that they may not be used to. Here's another tip for encounters with people from other cultures. So this is something I found during the research. It's called the LEARN model, a template for improved communication in cross-cultural patient healthcare staff interventions. So L for listen to the patient's perspective, E for explain and share your own perspective, A for acknowledge the differences between maybe your perspective and theirs, recommend treatment is R, and then N, negotiate mutually agreed upon plans. We talked about not using clinical jargon, and that is really, really helpful. So instead of, for example, saying hypertension, you could say high blood pressure instead of pulmonary, related to breathing instead of endocrinologist, your diabetes doctor, your heart doctor, what's your average blood sugar, then what's your hemoglobin A1C. I really like this approach too, always summarizing or using strength-based person first language when talking to and about patients. So start with what they know and what they're doing well. So when I'm interviewing someone and getting nutritional, history, I may say, wow, I see some real strengths here. You have someone in the house that likes to cook. You seem to be able to get the foods that you need, and you eat 3 meals a day. So I'll summarize what they're doing really well. And then we'll talk about maybe some ways to even build upon those strengths. And I think that is very, very empowering for people. And when you're writing about people and documenting, think about the wording too. So instead of saying, Sam is non-compliant with his insulin taking, you might think about why he's not taking it, because this can be very helpful for the next person that's going to be working with Sam. Sam is taking less insulin than prescribed because of a fear of hypoglycemia. And then, of course, not labeling people, but saying Sam has diabetes instead of Sam is a diabetic. Low literacy resources that I found on the internet. So scripts.org/diabetes. This is an example of their insulin handouts, which I love. All pictures in order, so easy to follow. They also have my plates in different languages with different cuisines. So you can pick handouts for providers in these different languages. And you can maybe print out a my plate that's more culturally appropriate for your patient. Scripts.org. This is the National Center for Farm Worker Health, and they have very, very simplistic handouts that are bilingual. So on the same page, it'll be in English and Spanish with lots of pictures, and low literacy as well. And then another one that I found that I've used is learningaboutdiabetes.org. Now, some of these you have to pay for the template, $20, and then it's yours and you can use it. And then some of them are free. So you just have to go onto the site and see and get the direction that you need on that. But they're very simple with pictures for low literacy. So here's the page with the resources that I found on it. And there may be many more that you guys already know about. And then I also wanted to just put in a plug for the ADA's, American Diabetes Association, free program called Project Power. I found this, I learned about this from actually a patient that went through my diabetes ed program. And she said she found this online and went ahead and signed up. But it's kind of like the DPP program for people with diabetes. And I like that because the DPP is just for people with prediabetes. So this is for people with diabetes, a lifestyle change. They have a coach. I think there's about 12 sessions or so, and they get free stuff. They also have it for youth, which is great because DPP is not targeted for youth either. So that's a free resource. And then another thing that might help people when they first start insulin and they have a correction scale, maybe you're wanting them to carb dose depending on, carb intake, is just to use some tools that do the calculating for them. So InPen and Bigfoot Unity are examples of two different types of smart pens that, you just put in your carb amount and your blood glucose, and it will give you calculate out. And if you just want to use correction, you can do that too. You don't have to use a carb ratio at all. So this might be helpful for maybe young people that got diagnosed with type 1 and, or adults that are struggling with using correction scale. They also have apps that are associated with them. And these are my references, so thank you.
Thank you, Karen.
You're welcome.
Great discussion. Any questions for Karen? So I had a thought and a question. This is something I was involved with about 15 years ago in Chicago, and it's the idea that health literacy is not a fixed characteristic of a person, that it varies through the course of their life, and it can be improved. And we set out to do that unsuccessfully. And we found it had to do with a lot of sort of heuristics or ways people had gone about their lives with low literacy in general. So, they don't read food labels, but they have a rough idea of what's healthy and what isn't. Is anyone aware of any effort to improve health literacy? In other words, not just to adjust everything that we do, but to give patients a chance to improve their own health literacy.
I don't know. But I like that. I like the idea of just using universal precautions of just kind of assuming that there's low health literacy and low literacy and just starting from a baseline of that, working with people.
Right.
There's so much information that's available on the net. I think regardless of somebody's situation, it seems like we're gathering information from the net. And I made the comment about the $64,000 question because how are we weeding out what's valid and what's not valid? Karen, your presentation could not be more timely. Thank you. I found it fascinating. We're doing weekly diabetes education classes for some of our clients. And a lot of the questions that they offer, it's apparent they've been hearing something, being told by somebody, or they've heard something on the net or what have you. And very often their questions aren't based in the science. And then we have to temper our response because, to your point, we don't want to give them a difficult to understand scientific response. So we have to figure out where they're coming from. I know I'm just kind of venting here a little bit, but to your question, Dr. Rao, I think there are beaucoup efforts to increase literacy, but we're having a difficult time weeding them out. What's valid and what's not valid, if that makes any sense.
Yeah, no, that's a great point. And here, just as an anecdote, you'll notice a lot of directions on bottles and vials refer to turning something clockwise versus counterclockwise. And it's been shown that a lot of people don't know exactly what that means. And it takes them a little while. They may have heard about it when they were in second grade or third grade, but it's lost. So keep that in mind. Thank you, Karen. Great presentation. Any additional questions? Angela, go ahead.
I will say that with the community health workers that are in my program, we do a lot of health modules and learning lessons that we do try to tailor specifically to our patients with whatever their diagnosis is, whatever the problem is that they're having. It's easier for us to do it in our setting, which means we directly go into the home. And with most of our clients, they're a lot more comfortable in the home, someone trying to give them information and teaching them about whatever it is that they're going through. And some of the cases that we have seen before, what is tailored specifically to them, things that they can do to help increase their knowledge of what's going on with their body, what the medication is for, what to ask your doctor when you go back to your specific visits. And I've noticed that it helped a lot with our patients that we work with.
Great, thank you.
I just wanted to make a quick comment, bounce that off of what Angela said. What you're talking about is really a personal one-on-one interaction. And you can tailor that interaction to the person you're speaking with. But the financial model for a lot of our diabetes education programs is do it on the, as cheaply as possible, so group. And I can't tell you how many times I've had people say, I went to those classes and I didn't learn anything. Thank you so much for, I just got so much more out of just the one-on-one. And unfortunately, the needs are not lined up with the financial reality that we're in. Too bad. But, like in our program, we can't just have, all right, we'll take whoever we have low health literacy and put them in one group. We're a small rural area. We try to, but maybe in a larger area, they can kind of tailor groups according to assessments they've made. I don't know.
That's true.
Thank you. Chris, did you have a comment? Go ahead.
Yeah, and I think the other piece to this, and I think Karen really hit on this within the presentation, is this separation between literacy and health literacy, because we have high education individuals that basically have very low health literacy because they're basically not reading the same type of information that we're providing. So just because they're able to read and able to comprehend information, this becomes just a completely foreign language, which I guess would be Latin at its source. But it really is, it's a separate language. So we've got people who, and I was just talking about this in class yesterday, a friend who had a master's degree in sports management. And he's like, how did I not know this interaction with my medication? He's like, I'm an educated individual, but like, you're not educated in the content that you're trying to consume. So being able to use that information just becomes a whole different kind of skill set.
Great, very true. So we are launching a new series with a moderately different format. We are going to take the summer off as we usually do. We have one more session in this series, and then our next series will actually be in February of 2025. And it is about combining echo with quality improvement. And the goal is, I mean, this is one of the well, I won't say criticisms, but one of the limitations of echo is I think all of you are participating. You're obviously very engaged. Your patients are benefiting from it. But there, you know, we aren't able to measure that very well. We can say, okay, people are generally happy and they've learned a lot. Would you have learned a lot anyway? And of course, this is a motivated group. So we are going to go through things in a more structured way and discuss quality improvement methods as they apply to cardiovascular risk. So we'll have a lot of the same content, but the goal is really to have people engaged in improving their own practice through reviews, etc. So we won't be going on a weekly basis. It will be a monthly basis, but in between monthly sessions, there will be opportunities to implement quality improvement strategies for cardiovascular risk. So if you're interested, of course, you're welcome to join, but if you're interested in finding out more, we're still in the planning stages. This will be led by me and Elise Caron from Metro Health. And we'll be co-leading this together with many members of the existing team. And we look forward to your input and participation. Let's see, next slide. Oh, I'm sorry. Andy, would you like to discuss our keynote as well?
Absolutely. Just as a reminder, our May webinar is coming up. You can register through our website or through the QR code. Next slide. All past and present cardio echo clinics are available to you on our website. And then a post-clinic survey was emailed to you. Please complete that by tomorrow at 5. Also, for our wrap-up session next week, we're asking for any remaining and outstanding questions you may have, and we can spend time addressing those. So please email them to me or include them in your post-clinic survey.
Thank you, Andy. And as far as the wrap-up session goes, I mean, the questions don't have to be, how do I dose insulin for this patient, or where do I get, you know, a continuous glucose monitor, et cetera. They don't have to be that discrete. They can be, what are your suggestions for dealing with a patient that, for example, Angela had mentioned today? It can be broader. And as Andy said, it's really an opportunity to tie up loose ends. So sometimes as you go through the series, you either don't have the opportunity to ask a question because we run out of time, or more often it triggers questions that you might have that we can address at the very end. And traditionally, these have been really interesting sessions. So I encourage you to send things along to Andy as soon as you can. Okay, we are all done, guys. Thank you very much. Great session this morning, and we'll see you next week. Bye-bye.